Welcome to Access Amplified, the podcast where we shine a light on how digital health is increasing access to care and advancing equity around the world. I'm your host, Joanna Brownold, and our podcast is brought to you by Taito Care. In each episode, we sit down with healthcare leaders who are doing the work to reimagine access and rebuild it from the ground up. Today, I'm joined by Dr. David Newman, Chief Medical Officer of Virtual Care at Sanford Health and a practicing endocrinologist. Welcome, David.
Great to be here.
Sanford Health is the largest rural health system in the US, serving communities across the upper Midwest. Dr. Newman has been an early adopter of virtual care in his own practice, and he leads efforts to make digital health central to how Sanford Health reaches their patients. Dr. Newman, I'm really excited to talk to you today. So let's get started. And I want to start right at the beginning in terms of the clinicians' journeys with training. Sanford started integrating virtual care into residency programs. So why did you make this a priority, and how are you preparing future physicians to deliver care confidently in a digital environment?
So being in the Midwest, we realized that we'd have to train residents differently. I love the title of your podcast, Access Amplified, is that we have massive problems with access in the Midwest. Personally, when I started practicing roughly 15 years ago, I noticed that my patients were driving very large distances to come see me as a subspecialist. I live in North Dakota, Parker, North Dakota, which is a fairly urban city, but a lot of my patients were coming from the western part of the state. I'm not joking when I say it's a 6-hour drive one way. This was completely unacceptable. And so we decided that we needed to think differently. So we leveraged telemedicine even 15 years ago so I could see my patients. This exploded during COVID, and the residents, the medical students, the young providers in training wanted to learn these new modalities because they wanted to integrate it into their practice, even post-COVID. We decided that, especially for our mental health residencies, or psychology, therapists, and psychiatry residencies, this had to be a priority. We opened a roughly $60 million virtual care building. And one of the pillars of this building was graduate medical education. So how do we teach the next generation of psychiatrists, psychologists, orthopedic surgeons, internists differently? We now have a curriculum for virtual care. When I was in medical school 20 years ago, Joanna, I learned a lot about how to do in-person care, how to do bedside manner, how to talk to a patient in person. I was never taught website manner. I was never taught how to be empathetic through a computer screen. These are things we're teaching. It is a sort of a misconception is that you can't have a really good relationship through a computer screen. Right now, my kids who are high school and college age, they talk to their friends all the time through screens, and they have that connection. We are teaching old doctors, new doctors, nurses, all of them how to do these things. A good kind of anecdote about this is I had a patient that I was seeing, and I was never able to connect with them in person.
Okay.
They were always anxious. I wasn't able to make eye contact. And for the visit, it was not rewarding for me or the patient. I said, hey, you know what? Let's do a virtual visit next time. And the next time I saw them, they were in their bedroom. They had their cat in their arms, and I was able to ask what the cat's name was. Right there, it was disarming for the patient. Level playing field.
Exactly.
I looked behind them, and I saw that they had a Red Hot Chili Peppers poster. So I asked about what bands they like. And immediately they were able to lose the anxiety, and we were able to have a productive visit. That this is definitely one of the huge modalities of healthcare in the future that we want our younger providers and our older providers to be comfortable. Another big thing we're looking at is augmented reality and virtual reality.
Interesting.
So you can imagine if you were an orthopedic surgery resident, how much better it would be to learn about a surgery through augmented reality and actually participate in the surgery before going to the operating room. 20 years ago, before I went to the operating room, I read from books. I read a couple of paragraphs about what to do in surgeries. Very unsatisfying. We're really bringing medical education into the current day.
That is very cool. And it's such a good use of that technology. I actually previously worked at a virtual reality company, and we did a lot of entertainment videos. We did music videos. Very, very cool. But I think seeing that technology develop into these kinds of use cases really showcases the capabilities and the potential of how people can learn from it. You also have mentioned to me previously, just kind of speaking of, you mentioned just now behavioral health, but you mentioned that you also have a model for supervising behavioral health trainees remotely. So not teaching them how to do remote care, but actually supervising them remotely. How does that work? And what kind of impact is that having on training capacity, I guess, especially in rural communities where specialists are often available in lower numbers?
Yeah, super good question. And again, it's all about access. In the Midwest where we are, and across all America, we've got a mental health crisis across the world. In rural America, roughly 70% of counties don't have a single psychiatrist. The big bottleneck is training. We have people that want to be therapists, that want to help, but they need to be supervised for roughly 2,000 hours before they can practice independently. Most rural clinics, they can't afford to pay a supervisor. This costs about $10,000 annually. And they also can't hire an unlicensed clinician without supervision. So we had to figure out how to get through this kind of catch.
Uh-huh.
We have solved this problem by providing virtual supervision at no cost to some clinics and at low cost to other clinics. And two of our supervisors can oversee 6 supervised remotely. We've done this for several small communities to get their licensees trained so they can provide care to their communities independently. It's been the only way that we've found to kind of train up licensees to treat their communities independently.
Is that also giving them more access to patients so they could potentially get through those hours faster?
Absolutely. Yes. And it's more satisfying for the people that are doing the supervising because they can do multiple trainings at the same time. It's much more efficient.
Right. That's very, very cool. And I love that idea of not having to be, especially for behavioral health, which always felt like it was kind of a shoe-in for virtual care. That's a great opportunity to leverage that. And are you seeing, obviously, you're kind of got all of these different training programs and protocols and remote supervision. Are you seeing that help Sanford Health to attract and retain clinicians? And does that then kind of, I'm assuming it kind of expands the pool of providers who are available to serve in rural areas, which is a challenge that rural areas across the US and the world are facing.
Absolutely. So we've noticed that this has been a necessity. Most providers are asking to do this. Let's talk
Okay.
about some specialty care for a second. So the norm 20 years ago was something called outreach, where some specialists would drive often several hours, often through blizzards, to get to the smaller community to serve their needs.
Uh-huh.
It was hard to recruit providers because they didn't want to outreach. It was not a great use of their time to be in a car for 6 hours in a day. Now, instead of outreach, we can flip that to virtual care. So we can have patients come to the clinic at an outside facility so they don't have to worry about technology. If they are concerned about their broadband access, if they're concerned about getting their computer to work, they can simply go to their local clinic and we can have some specialists see them virtually. Using peripheral devices, we can listen to their heart, we can listen to their lungs, we can look in their throat and their ears, and it's a very satisfying visit for both the patient and the provider. For rural communities, this means a lot more stability. So the providers, the family practice providers, don't have to worry about doing everything themselves.
Uh-huh.
If there is a single nurse practitioner or a single physician assistant in the smaller community, they are not on an island. They have the tertiary care that they need to feel comfortable providing care.
Yeah, I was going to say, because we get that feedback from a lot of partners, but specifically like school nurses, for example. One of my colleagues called them an island in a sea of educators, and I assume it's similar like that for rural clinicians if they're or rural practitioners if they're the only doctor in the village, so to speak. I can imagine that can be very daunting for them.
Right, right. So in the past, if you were an ER doctor or an ER nurse practitioner, physician's assistant nurse, and the patient came in, you're kind of all by yourself. We have set up programs now where you can literally hit a button on your wall and a board certified ER doctor from one of our hub hospitals, our bigger hospitals, can beam into the room and you can see them on the screen. They can see the patient and they can help you walk through the cares that you need. So we want our communities to know that we're invested in them. They want us, we want them to feel very comfortable treating all of the patients.
That's very, very, very interesting. I actually kind of want to ask a little bit because you mentioned just now like hub clinics, and that's like the hub and spoke model that we've spoken about before. How does that approach help? I assume that this approach is also helping patients who don't have good access to internet at home, or maybe they're not comfortable using technology at home. It's not so simple for rural areas to just kind of make a phone call, a video call, and and connect to a clinician that way. Are you seeing that really helps them access care locally, but still have access to those specialists or that wider network?
Yeah, absolutely. So our kind of motto is it's the right care for the right patient at the right time. That we want to meet patients where they're at. A lot of our patients are very comfortable using technology at home. They've got broadband access, and surprisingly, we're not having a ton of issues with broadband.
Okay.
My kind of question that I ask my patients is, have you ever ordered anything from your phone? Have you ever bought anything from your phone and have it delivered? If you can do that, you can do virtual care. Or have you ever FaceTimed your kids or your grandkids or your friends? It's the same type of things that it's a couple clicks on your phone and you can get in. If they're not comfortable with this, we'll meet them where they're at. I have a patient that lives in southwest North Dakota on a ranch and does not have broadband access, does not have a smartphone. What he does have is a rotary phone from like the 1970s and 80s. We're
Okay.
talking yeah, we're talking like it's got the dial that you spin and it's got the 20-foot long braided cord that you can
Or
take to
that,
several rooms.
yeah.
Yes, yep. And we do virtual care that way. That we call and I talk to him about his diabetes every 3 months. And it saves him a trip to Fargo. And the last time I talked with him, he was literally in the middle of calving season and was able to do his 20-minute touch base by phone and then go out and help with calving. But these are
That's
the
so
kind of things, the innovative care models we're delivering.
Yeah, and that's his livelihood. I mean, his livelihood is being on a farm. If he's losing a day that day, he's potentially losing. I'm not a cow expert, but he's losing calving opportunities.
Yes, I'm also not a cow expert, but he raves about this. Yes, that just because of the opportunity cost is so high to come see a doctor at points that it's a barrier for a lot of patients. That it is for a lot of the patients, it's virtual care or no care at all. But we also have other. You talk about the hub and spoke. So one of the things that we're very proud about is our satellite clinics. So as part of the
Uh-huh.
initiative funding that we received to transform care in rural America, we started different hub and spokes for different patient populations. One of them was small town America. So in Lidgerwood, North Dakota, roughly a town of about 600 people, they had a bricks and mortar clinic that was very underutilized. Was utilized for a day and a half, 2 days a week with a nurse practitioner or physician's assistant. The town said we would love to have this open 5 days a week because they wanted a local provider. So we switched it to a virtual clinic for the other 3 days a week. Same provider, someone they're comfortable with, but it was fairly underutilized.
Okay.
For whatever reason, only a couple of visits were being done a day, and we weren't showing the growth that we thought we were going to. So I actually did a couple boots on the ground reconnaissance visits to Lidgerwood as I drove there personally, and I filled up my
Mhm.
car with gas at the one gas station, and I talked to the gas station attendant. I
Okay.
went to the one lunch counter and I had lunch there. I went to the coffee shop and got a cup of coffee, talked with the coffee shop owner, and I went to the bar and had a beer at the bar. And everybody said the same thing is they wanted to see their subspecialists. They didn't want to drive to Fargo, the hub. They wanted to
Mhm.
go to the spoke to see their ENT doctor or the endocrinologist.
Okay.
So within a couple of weeks, we pivoted and we had 5 specialties set up. And we saw that the utilization went way up. I
Wow.
went back about 6 months later to see how it was going, and I talked with the coffee shop owner who was going through treatment for breast cancer. She gave me a huge hug and said that she had gotten a day a month back out of her life.
Wow.
She literally walked across the street, was able to get her labs drawn, was able to get imaging done, and was able to visit with her oncologist, and then walked back to her coffee shop. She could flip the sign on her door to say, be back in 30 minutes, instead of closing her shop down for an entire
For the
day.
whole day. Yeah. I have a very important follow-up question. When you said you were doing reconnaissance, were you like wearing a Mac and like a hat?
No, no, I just went wearing street clothes, but I wear street clothes typically when I'm seeing patients too. No, I did not have a stethoscope around my neck. So I was kind of incognito. Great question.
There you go. Covering all the important points here.
Yes.
And how have you found, so obviously you mentioned the patient with the rotary phone. I know that you mentioned kind of exams from home as well. How easy is it or how difficult is it to adapt to the care depending on different patients' situation and their capabilities? Like how do you gauge what they're going to be comfortable with and then tailor your visit accordingly?
Yeah, a lot of it is asking the patient what they're comfortable with. And then now, as we've got a little bit more mature, we can guess what the patient's going to be comfortable with or what the setting's going to be comfortable with. For example, we talked about hub and spoke. We talked about being innovative for care delivery models. One of our next satellite clinics is going to be in a pediatric group home where very complicated patients, some of these kids are on ventilators, and transporting them to and from clinic visits was very resource intensive. You can
Yeah.
imagine that they have to have 3 or 4 people accompany them to their visits, which would be a half an hour visit. Now, by setting up a virtual clinic in the group home, we just move a cart into their room. There is way less disruption to the patient, to the providers, and we're able to see them where they are. That we were able to anticipate the needs that they have and meet them where they are to deliver them.
I think something that's very interesting about this is I see you're really listening to your patients and you're getting that feedback live and then you're implementing it. Um, do you find that easy to kind of, you said within 2 weeks you had 5 different specialties available. Is that easy to pivot that so fast? Or is there a way that you're building that system of capabilities to pivot, to add, to change within Sanford Health?
It's a great question, and I would say yes and no. So it's easy to pivot some of the technology if it's already built. It's harder for the change management to get providers on board. So while this is a fairly new
Mm-hmm.
modality, we have to do training for this. We have to invite people in, and they have to accept the invitation. One of my roles now is to go in to talk to doctors and nurses and show them how powerful this is. Times they come in and they said that their patients have been asking for this, and so they're asking for the training. That's where we're getting more now. Is we're selling it less, and we're more people, I guess, are buying it because of consumer demand.
That's great. That was going to be my next question is like, how are you selling internally? But it's interesting that it's kind of coming from the bottom up that you're getting those requests that you're getting. That just really shows how much telehealth has changed, grown, adapted, and become part of what we're expecting at this point from healthcare
Right.
almost. I want to talk about a little bit of a different kind of angle because something that you've mentioned to me in the past is how Sanford is using scale and purchasing power and kind of working with other smaller health systems to provide technology, operational support, infrastructure to those that potentially wouldn't otherwise have access to those resources. And I really love this as an idea of kind of, you're a big player in rural healthcare. There are other small players that don't necessarily have the same capacities that you would. Can you tell us a little bit about that, how that works, and the impact that you're seeing from that?
Yeah, absolutely. So at Sanford, we firmly believe that we're all in this together. Is that, there's a patient at the end of every story that we tell about this podcast. There could be patients listening to this that need access to care in rural America. And we want to help all of our critical access hospitals, all of our outside facilities that might not have the same access to scale that we have at Sanford. So we are very large at Sanford and we're able to leverage our size for purchasing power. We can make advanced tools affordable and sustainable, and we can help our smaller towns get access to those same tools. A good example of this is we kind of help smaller hospitals get EMR access. Is we're able to lease out our EMR so they have access to these tools. The same way for virtual care, that if they have our EMR, they can have access to virtual visits. That if the only way that we make people healthier in zip code based disparities is by leveraging all these tools together and kind of being one.
Love that. Ultimately, as you said, the thing that matters the most is the patient being healthy and how we get there as a group and as a team. A bit of a more kind of personal question now. You've been at Sanford Health for over 13 years. That's a long time. What keeps you inspired? And what are you most proud of in the work that you're doing now?
It's the advancement of care. So I see how far care has come in the Midwest in the past 13 years, and my jaw just kind of drops. When I first started, it was so inconvenient for so many patients having to drive long distances. And for so many of my colleagues that, like we talked before about outreach, they were upset on their outreach days. That has gone away. North Dakota, we have blizzards frequently. I remember showing up on a day where we would have a blizzard and my entire day would be wiped out. As one of the only endocrinologists in the state, the patients had to reschedule for like 6 months later. And it was so unsatisfying. Now we can flip them all to virtual visits and they can be seen from the comfort of their own home. We are seeing lots of innovations with artificial intelligence come into our visits. These are things that are making patients healthier. A lot of it is not just the technology, but the way that at Sanford we put the work in that can strengthen the care and the relationships and making access better. This is just making healthcare, I guess the common buzz term now is frictionless, right? But that's actually right. Is it's so much easier to access your primary care doctor, your subspecialist, and get high quality, high value care.
Thank you so much for sharing, David. I really appreciated it. Thank you for joining us today.
Absolutely. I appreciate the invite.
Thank you again. If you enjoyed today's conversation, please be sure to follow or subscribe wherever you get your podcasts. New episodes drop every 2 weeks. And please share this episode with a colleague or a friend or a family member who is passionate about digital health access and rethinking care delivery. Access Amplified is brought to you by Taito Care. I'm Joanna Brownold. Thank you so much for listening, and we'll see you next time.